So good afternoon, everybody, and thank you for coming to the IDF Europe seminar. And thank you to all our sponsors and some old friends and some new friends out here. I'm Dr. Niti Paul, and I'm the president of IDF Europe. I was coming in the plane, and one of my friends met me on the plane and said, "What do you do?" And I had to think about 5 times about that one. And the reason I'm here, and my claim to fame, is my son has type 1, and he's now 31. He had it when he was 3 years old. So I've been a diabetes advocate forever. And I've been in the presidency for 3 years now. And my dear friend, Nebosa Lalic, who's here. Nebosa, do you want to stand up and just be known? Professor Lalic is the incoming president, so he'll be closing the seminar. Just today, we're talking about a really important and interesting topic to us. I have been a primary care physician in the UK for as long as I know. I've been in healthcare for 35 years. And I was in an inner city practice in Birmingham. It is the center of the universe, if people don't know where it is. Birmingham, United Kingdom, not Alabama. And I worked there for 17 years as a primary care physician. And actually, my patients taught me everything that I have to know. They made me a better doctor. They taught me about medicine. They taught me about how to be a better human being. And I learned everything about medicine, not when I was in medical school, but from my patients. So that relationship of the healthcare professional with their patients is probably the most important relationship. It's a therapeutic relationship that really matters. And for us, that's why we're discussing this today. At IDF Europe, we think we are the voice of people with diabetes. We have lots of professionals who engage with us. I'm a doctor myself, and we have a lot of member associations that are professional associations. But this is at the heart of what we should be talking about and what health systems should be talking about, and which is what we're going to discuss today. Just leave you with a little anecdote. So I also work as a health systems consultant in about 40 countries around the world. That's my day job. And I have always found 4 things that matter to healthcare consumers. And I work a lot in low and middle income countries. I work across the world with universal healthcare. And the 4 things that matter to healthcare consumers everywhere I've been, and I've tested it in many, many countries, is trust, empathy, expertise, and information, in that order. If your trust and empathy doesn't exist with your patients, they never take your expertise and information. I leave you with that thought to think about, because if you don't have that in your system, you will never get to the point of actually achieving great health outcomes. And that's what this is all about. So I'd like to invite onto stage now Sabine Dupont, who works with us in the regional office, and she's going to tell you some of the work that we've done. Thank you, Sabine.
Thank you, Niti. You want that? No, that's okay. Thank you. Good afternoon. So I'm going to present the preliminary results of some work that we have been doing with our platform of people living with type 2 diabetes on the relationship between the person living with diabetes and their main healthcare professional. And, sorry? So the reason, is that better? The reason that we are doing this is that IDF Europe's vision is really to improve the lives of people living with diabetes. And we do that around 3 priority objectives: improving access to care and quality of life, reducing incidence and lowering the risk of people developing complications, and very importantly, increasing the voice of people living with diabetes, ensuring that they're empowered to engage. And we have had many activities with youth. We have been running youth leadership camps for more than 10 years, really trying to nurture a community of advocates. We have an established type 1 community, but, you know, as is notorious, engaging with people living with type 2, seeing how they want to work and advocate, what they want to advocate for, has been a little trickier. So last year we launched a platform of people living with diabetes, and in the first consultation that we had with them, the topic that came out very strongly was that what mattered to them was the relationship that they have with their healthcare professional. So whilst we continue to work with the platform to see what they want to engage on, how, which is actually perhaps very different from the way that the type 1 community engages, we have also set up a working group working on the relationship between healthcare professionals and people living with diabetes. And that working group, we had a literature review to inform the consultations that we had with the group. We had a series of online consultations where we tried to tease out really what are the key factors that are at play when we talk about the relationship between the person living with diabetes and their healthcare professional. We then had a survey over the past couple of weeks, just for sake of simplicity and time, to just validate some of the findings and to try get a bit of a ranking of the factors that we discussed during the group. So we had about 50 responses, of which 25 exploitable responses from people living with type 2. We're not and other types of diabetes. We're not excluding the type 1 community, but this work here is about what people living with type 2 are saying. And of those 25 responses, about 2/3 of people lived in a city, half of them were between 31 and 59, and about 1/4 of them were on insulin therapy. So the first question that we ask them is whether they do believe that the quality of their relationship affect their health outcomes. And as with the focus group, obviously pretty much everybody agreed that this relationship is key to ensuring that they have better health outcomes. And even on the logistics of making an appointment, going to follow your treatment plan, that relationship is actually a very important driver for them. So we then try to see, okay, when we talk about the relationship between people living with diabetes and healthcare professional, mostly people think about the communication that goes on. But we try to look at that relationship beyond the communication aspect. And we listed about 31 individual factors that we think have an influence on the quality of that relationship. And those factors can be bucketed into about 6 categories. And what is interesting to Niti's point is that the category that came up as having the most influence was the expertise that the healthcare professional has, but very closely followed by the way that the healthcare professional engages with the person and how they communicate. Other things such as personal factors, the way that they feel about their diabetes or the way that they feel about the society's perception of diabetes, whether they've got access to other services, the multidisciplinary team were seen as slightly less important factors influencing the relationship. So when we ranked in order of importance, so the questions that were asked is, please rank between 1 and 5, with 5 being the most important factor, which one of these 31 individual factors is the most important? What came up top was the knowledge that the healthcare professional has of the way that diabetes should be managed, their knowledge of the condition itself, and also the way that they approach treatment decisions. How fast are they to change the treatment? How do they adapt that treatment to the person that they have in front of them? And then it's about the honesty. The honesty, it's in talking about the health outcomes. So it's not about infantilizing them. It's not about frightening them. It's about having an honest and decent conversation about where they are and what needs to happen and what could happen. Bottom of the list, which we thought perhaps would be also important factors, and they're still important, but towards the bottom, they're slightly below average, so they're really the least important of the factors that we've looked at, where the healthcare professionals link with the community. We'll come back to that later. People want to be directed towards relevant resources, but they don't need their healthcare professional to be really embedded into the community. And the feelings about how they've managed their diabetes since the last interaction, or how society has seen their management of diabetes, is important, but not as much as other factors. So looking specifically at the bucket, engagement and communication, what we see is, as I said, the honesty, and then obviously the way that the information is shared. Is it clear? Is it structured? Is it in a language that everybody can understand? And third most important factor was the willingness to agree and discuss the treatment plan. So the shared decision making, having real and meaningful shared decision making. So then we asked them about the environment in which the healthcare professional operates and personal factors affecting the way that they may interact with their healthcare professional. And there we can see is that the healthcare professional's capacity to coordinate the care, to facilitate the pathway, is important, but just not so important as other factors. And looking at personal factors, their mood during the visit is the factor that they recognize as being most important compared to the way that they have managed their diabetes before. So then we asked what are the factors that they would consider would help improve the relationship that they have with healthcare professionals. And perhaps not surprisingly, having more educated healthcare professional was what came top. And they would like healthcare professional, particularly in primary care, to have diabetes management included as part of the standard curriculum, but not just that, making sure that that education is refreshed on a regular basis. Now, they also recognize that self-management education is key, and again, very often was seen as being lacking by the people in our panel. And then communication skills. Surprisingly, perhaps we have to broaden the base of people, but the frequency and the duration of visits that they had either with their main healthcare professional or with other healthcare professional was seen as less important than the expertise, the communication, etc. Because we thought that, you know, people always ask for more time, but that was not the case. So in conclusion, we can say, you know, expertise and communication skills are really key to the relationship, and both are seen as lacking. People living with diabetes value a kind and honest discussion about their health and their health prospect. They want to be listened to and not judged. They don't want, as I said, they don't want to be infantilized. They don't want to be frightened into taking a particular course of action. They are aware and they are desirous of having more self-management education, and to them the outside environment matters less to them than the immediate relationship that they have with their healthcare professional. So this is very much the first step in the work that we're doing. We are letting the survey run for another couple of weeks to see, but so far it has been very, very consensual. I mean, we haven't had any surprise, I suppose, or there hasn't been a huge, there haven't been new factors that have come in that we had not studied before. And then the next step will be to extend the consultations to the healthcare professionals themselves, to see what they think is key in the relationship that they have with people living with diabetes. And then the idea is to bring the two groups together to work out what we need to do and how, as an organization, we can support an improvement in that relationship. So we'll put together an action plan based on those consultations. And that's it.
Much, Sabine. That was a whistle-stop tour. It's always difficult to do this kind of qualitative analysis, right? And to get to the, you know, I'm sure you had richness of answers and questions that came from people living with diabetes. And it's like we said, it's a work in progress. We're not excluding type 1. It will be, we will be including the type 1. We've been talking quite a lot to you over the years, but we really wanted to get another perspective as well. So that's where we are. So I'm going to invite onto the stage our next panel. And the next panel is João from Portugal. I'll let you introduce yourself in a minute. Elena Shavastova. Yvonne is already on stage. Thank you, Yvonne. And Pinar. Sit yourselves wherever you want to, wherever you'd like. I think I might plonk myself here, so you might want to sit here. And I might want to give another, I'll give this to you guys to hold. Does that work? That works. Okay. So if I may, I'm going to sit down too, and I'm going to, it's a panel discussion. We're not doing slides. I hate doing slides. You'll be death by PowerPoint in three panels. So the first panel, we're going to talk about the relationship between the healthcare professional and the patient with diabetes and how to support a multidisciplinary approach. So in kind of what we do, there's in places like the UK and in Portugal, I know, João, we have very much have a multidisciplinary approach, and I know my lovely friend Eleanor here has been kind of advocating for that in many, many places. And Pinar, of course, you're a primary care doctor like me. But first of all, I'd like you all to introduce yourselves. Pinar, can I start with you? Could you introduce yourself, please?
Yes. It's working. Okay. Thank you, Niti. First of all, thank you and IDF very much on behalf of Primary Care Diabetes Europe to include the primary care doctor's voice in this panel. And also on my behalf, it's a pleasure and an honor to be here. I'm a GP or a family physician, how we call it in Turkey, and I come from Istanbul, Turkey. And I am also an academic GP, meaning that I work at the university department of family medicine and general practice. And there, because it was just mentioned in the results of the survey, there we do training of undergraduate medical students as well as residents in general practice and family medicine, where we have, of course, a very strong emphasis on the clinical approach in a patient-centered manner to the multi-morbid patient, and diabetes in my country, at least unfortunately, being very prevalent, is one of the main actually conditions that is dealt with in this curriculum. And and I'm a GP with special interest in diabetes, and I'm also working at Primary Care Diabetes Europe, and currently I'm the vice chair of this
Thank you so much. Elena, over to you. Thank you. That's great, Annie.
Good afternoon, everybody. I'm Elena Shelistova from Georgia. I want to say thank you to the board of IDF Europe for inviting me here, because it's really a privilege to be here and to speak for you. I work at the Georgian National Center for Diabetes Research. I'm a diabetes nurse and diabetes educator. For 6 years, I was the IDF board member, and it was a wonderful experience to work with such wonderful people. Lately, I had also it was very important and interesting. I was the member of European Society of Endocrinology Nurse Section board member. And it was really very interesting to know the broader aspect of nursing in Europe. In Georgia, nursing is still very neglected. And I am really working hard together with my colleagues to change the situation. Thank you very much.
Thank you, Elena. Yvonne.
I'm a lay person. I'm not a medic. I have no medical qualifications whatsoever, but I am a food technologist by profession. I'm retired now, and I work full-time, but I work for the cause of diabetes. I've had diabetes for over 30 years. I'm type 2, but my family can go back 3 generations of everyone having diabetes. So that is why I'm so passionate and fired up to support patients with diabetes. I run 5 patient reference groups and peer groups in North Wales, where I live. I sit on the All Wales Patient Diabetes Reference Group that works very closely with the government, the Welsh Government. I sit on the NICE panel when they're reviewing diabetes. In fact, I work full-time for diabetes, but as a volunteer. And I'm here today, and I feel very privileged to be able to be invited here. And I hope that I will be able to give you the patient's perspective, because we are the important people that you are looking after. And you need to know what it's like, if you haven't got diabetes, what it's like to live with diabetes.
Thank you, Yvonne. And we're so privileged to have you here. Thank you so much for working with us. João.
So let me reinforce this sharing of privilege feeling that I also feel at this moment. So thank you for the invitation to be here. It's an honor to be here and to be part of this group. I also think that we should congratulate IDF member associations and the IDF board for having this courage to still do this kind of events and keep this fight alive through the world and in the European region particularly. And it's good to be here live with people after all these years. So it's also, and we are speaking about interaction, and we know how difficult is interaction and the difference between live interaction and online interaction. And so I'm João Raposo, as you said, tough name for most people, and I'm medical director of the Portuguese Diabetes Association. As you might know, it's the oldest diabetes association in the world, was founded 96 years ago, but it's a unique model of association because in the same association we have the patient organization, we have an outpatient clinic for people with diabetes with an interdisciplinary approach, we have a research center, and we are conducting also the training either of healthcare professionals, either from people with diabetes, either from other lay people in the community, creating awareness of diabetes throughout the community. And we also try to be active part of IDF, collaborating in everything.
Always.
And we are there exactly for that. Apart of that, I'm an endocrinologist. I'm also a professor of public health in the Nova Medical School, and many other functions.
Thank you, João. And you are a great supporter. I'll endorse that completely. And the Portuguese Diabetes Association is one of the oldest in Europe. I think it is the oldest in Europe. In the world. In the world, gosh, of course. So that's, and it's an amazing association. So I'm going to open up the discussion now, and I'll perhaps start with you, Yvonne, on your kind of, your story. Just on that question of multidisciplinary teams and the relationship with people with diabetes, do you think that's important? Do you think it kind of, and what is important in that kind of approach?
Very, very important. One key requirement is for access to up-to-date information, evidence-based care, and that is one of good communication and good rapport with the patient. The patient has to feel confident, and there hasn't got to be repeated information that contradicts. I'm talking now on behalf of the patients that I work with, not me personally, because I'm very lucky. I am well cared for, and of course they know that I will be there if I'm not, because I know working with these people, with the professionals, with the health board, that I am well looked after. So I am giving you the information, not of me personally, but of all the patients. I have over 100 patients that I look after in my peer and reference groups, and they change all the time because some people drop in and drop out. It's like a one-stop shop situation. So we have developed in North Wales a one-stop shop with the healthcare professionals. And when people come for their checkup, they have everything together. It's a pilot project that is being done in Denbighshire. And the patient has an appointment, and they're there for about an hour, and they have their ACR, their blood pressure, their H1B taken, and they, at the end, they have this done with a proficient, trained healthcare professional and the consultant or their GP. And at the end of that time, they then sit down and they work together. And I emphasize the work together, because if you don't get the patient on board, they go away and they put down their care plan and they forget it until they're called again in either 6 months or 12 months' time. So they work together to agree what they're going to do, not to be told what they have to do. Because if you tell somebody, they're not as receptive to accepting it. So they work together, because everybody, even though they've got type 2 or type 1, are individuals. They have a mindset of their own. They may have other conditions that can affect them, and they have a life to lead. And very often, stress or pressure can affect their diabetes as well. So you have to look at each patient individually. I know it's a formidable task, but if you do that, then you win that patient and it helps.
Thank you so much, Yvonne. I mean, that, you know, there's so much to unpick and such a rich conversation to have with you, and I'm sure the other panelists will join in that. So I'm going to switch over to Pinar. I mean, I know what primary care doctors do, and I have multidisciplinary. I used to have in my practice. I'll bring that question. So Yvonne has raised some really important issues in personalized care. She's talked about, you know, having a one-stop shop. She's talked about that communication between professionals, so you don't have to repeat yourself. And I can tell you a story or two about that. My son was 6, and he told his diabetes nurse and his diabetes endocrinologist, "Why do you all see me separately? And why do I have to tell you my story over and over? Can't you all sit in one room and see me together?" And they did listen to him and change their the way they ran their clinic. So I'm sure those are stories that can be told.
It's very important, especially if you live in a rural area where you may have to have a taxi or get somebody to take you for that. And if you've got to go 3 or 4 times, maybe within a couple of weeks, it's not only expensive, but then very often they don't turn up.
Correct. So Pinar, over to you. So that relationship between the healthcare professional and the patient, we're exploring that in the multidisciplinary team setting. What role do you think primary care has to play in that? Because there's been a whole focus on that recently.
Session, we had 2 meetings, and we already had these fantastic discussions before, and also took our notes, and Sabine was so kind to circulate them. Actually, what Yvonne was saying, or if you would like me to tweet what I got out of Yvonne, is that she said, we don't want fragmentation of care. And I do believe that integration is something that people with living with diabetes and their healthcare providers will create together, because they will empower each other. If there is the demand, I was very, very impressed by your one-stop shop, you know, this point of care hub, fantastic idea. And that can really, it's not so expensive. It definitely is not impossible to do. But what's very important is the communication. Of course, the healthcare provider needs to have good communication with the person living with diabetes. But what's very important here, and what Yvonne was saying, what your son was telling you, is that the communication between the people in the diabetes team must be seamless as well. So you do not have to tell the whole story over and over again. Definitely, you shouldn't be obliged to go through that cumbersome task to hop on a taxi and visit 3 different loci to receive diabetes care. So it should be integrated, and the levels of care, so the level of expertise should be integrated, and it should be, although it came out in this survey that the location is not so important, but let's just imagine for a moment, we would take away all the community-based primary care centers. Then suddenly, if they're not there anymore due to decreased access to healthcare, pure geographically, it would come out how important it is. So I do believe that it's a very good idea to have these skills mixed diabetes teams, but located in the community, and that's per definition primary care.
Thank you, Pinar. Thank you.
And we also have the cardio as well.
Yeah, thank you. So I'm going to bring in Eleanor. Eleanor, you're a diabetes nurse and an educator of very big standing, and you've been doing this for many years. And of course, in places like the UK, we've had the diabetes specialist nurse forever. I don't think I would have managed my son's diabetes, and I still remember the names of those diabetes nurses, Adele, Emma. I remember them very well. I have never forgotten them, because they helped us get to where we are. So just exploring that relationship of the multidisciplinary team, the role of the nurse, and the relationship with healthcare professionals with each other in facilitating that conversation with the patient. Could you just comment on that, please,
You
Elena?
are happy and lucky just to have strong nurses and to have healthcare system where nurse occupies its strong position. Yeah. Unfortunately, in Eastern European part of the region, the situation is not like that. We are still, as I said, neglected, and we have to fight just to occupy our position. But I may say that nurses are very important, maybe pivotal part of the system. And as Niti said, and I remember late Alois Rudolph telling that their GPs give very good results because they work with several diabetes nurses who are supporting their activity. And I truly believe that if GP is just cooperating with nurses who take care of patients from one visit till the next visit throughout the year and longer, the situation would be much better, of course. I had the pleasure, as I said, to work with the Endocrine Society, and I translated the publication that was out last year. It was the competency framework of endocrine nurses. And I like very much the phrase, in each competency, it was written that nurse should be able to facilitate interaction between the multidisciplinary team, and she should be able to teach other specialists working in the same medical setting. So people who are not, I mean the healthcare professionals, those who are not diabetologists or endocrinologists, they'll miss a lot of knowledge in diabetes. And here of course, we can do a lot to, first of all, as Pinar said, to make the seamless relation where the team and the work is like a big puzzle. When you look from 2 or 3 steps away, you see a picture, but when you come closer, you see that each piece is just a little bit intruding into another, creating real contacts. And you know, I just forgot to tell you that in 2004, being the member of Diabetes Education Study Group, absolutely unexpectedly for me, and I was the first in the family, I found that I have prediabetes. So it is almost 20 years I'm fighting this disease, just because there are always people around me who work like one organism, helping each other, supporting each other, and sharing knowledge with us people. In this situation, I'm already a person who needs support and attention.
Thank you, Elena, and you always do a great job for us. Over to you, Joao. And I know that APDP, you're the oldest association. You also provide care to people with diabetes, which is like not many associations. Any other associations here? Hands up. Tanya's from Macedonia. You're from Georgia. I've got Kostas from Greece. We've got Italy. We've got Serbia. So we've got Aldona from Lithuania. So we've got many national. That's not the case. Many associations do support and advocacy, but don't actually provide care. You do. So again, coming back to this question, that relationship between the healthcare professional and the person with diabetes and the multidisciplinary approach. The facilitation that I guess you guys provide for that, how would you describe that? How would you describe from APDP's perspective, from your own perspective as a doctor, how important is that?
Okay, so let's start just to say to Yvonne that if you have been in Portugal at APDP for the last 90 years, you would have that one-stop consultation with the multidisciplinary team. We have been doing that for many years. We have demonstrated to the healthcare system that it saves money, it promotes better quality of life. Still, more than 90 years later, we are still discussing exactly the same things. What's the pattern of the better care for people living with diabetes? What's the best organization of the health system for people with diabetes? And we are still surprised with the data that Sabine showed that trust is important, that communication is important, more than technical skills. So we are really missing something because we are still doing exactly the same discussion. If we were here sitting 50 years ago, we'd be discussing the relevance of communication. And so probably we are missing something to really get to the point of providing better care for people living with diabetes. So I'm not sure if it's the discussion between what's the role of primary care or who will be in the primary care. I think we are still trying to fit the needs of people living with diabetes to the health system and not doing the opposite. We are not relying on people's needs to design the new health system that people would need. We are taking too much time to do that. And that's the core, because we all know that communication is important. We have been giving courses on communication, on education. Some of you have been there for the international courses on patient education. Guidelines are there, so technically most of the healthcare providers are experts on the guidelines, on proficiency techniques. And so we have to move to another level of this discussion, because we know how to take care of people with diabetes. People with diabetes know what kind of care they need. So why is it so difficult to merge those two feelings and work together to have better care? Probably we'll have to aim to a higher level of intervention at the government, policy makers, because we are much aligned in what we need. We may have some differences in language, but it really doesn't mean anything. We may speak about empowerment, capacitation, health literacy, all those buzzwords. Now it's the multidisciplinary or the interdisciplinary approach or the integration of care. We are always trying to find the right word to define something that we all know by heart. And so, of course, the relationship is the key element of any healthcare provider, people living with a condition relationship. So it's why do we have any doubts on the importance of that?
No.
No. And then we are trying, and the concept of the multidisciplinary approach, I think there's some dangers on that, because we are always justifying our absence of providing the best care, saying that we are missing. First, it was just the time of our consultation, when we are not taught to have the best use of the time. Then it was missing the nurse role, missing the dietitian or nutritionist, the physical activity, the psychologist, and we can add another element for the multidisciplinary. And of course, they are all important, but if we don't take care of the integration of care, of the interaction between the healthcare team and the patient and the people living with diabetes, being sure that he is in the process, that we all know the needs, that we all know the information, that we are not repeating. But those are basic things of training the healthcare teams. So that's not so different from anything else. There's a good definition of integration care from Patient Voice from the UK.
Yes.
That's when it says like something like, my care is provided by a team of people that work together, that know me and my caregivers, and they provide me the best care considering my conditions and the resources available, so as I can have the best quality of life and the best outcomes for me. And I think it says everything about this, so we don't need such a huge discussion on the relationship, but we should discuss a lot how to get there.
Excellent, thank you for that. And we're running out of time. What a great note to end the discussion, but I'll leave you with one thought, and that is, why isn't the patient part of the multidisciplinary team? Because actually that's who they are, and that's how we felt we were. Any quick questions to the panel? Happy to take any questions, comments, anyone? I'm sure you have lots to say, guys, come on. No? No comments to the panel, I have one. Please say who you are, sir.
See that you have the facility to have this multidisciplinary approach to the patients. But for last 35 years in my practice and in our area of practice, normally we are the only person to take care of everything. Counseling, dieting, this thing, and everything is done solely by a doctor, primary care physician, or diabetes expert. In big houses, there are this multidisciplinary approach. And I'm learning so many those key points about the asking the questionnaire to the people with diabetes. That's nice. Thank you.
That's such a great intervention. Thank you for that. So we really appreciate your being here all the way from India. I am a Delhi girl myself, and I understand entirely where you're coming from. So, so there are countries, and like I said, I work in lots of low and middle income countries where, I don't know whether you know, that we will be short of 60 million doctors and nurses worldwide by the year 2030. It's going to hit you in Europe as well. So you know, the multidisciplinary approach, I think, becomes even more important when we're short of lots of very well-qualified healthcare professionals. So I'd like you to thank my panel with a big hand. Jean wants to say something.
No, just
please.
to add that multidisciplinary, that you were speaking about the shortage of doctors and nurses, and the relevance of integrating also lay people, train lay people on this, at this level of care also. So
thank you. Any last point for you to make before I thank you all?
May I add something? So I want to I agree with you absolutely. There is nothing to talk about between us, yeah? We all know what is multidisciplinary approach. We all know what is better for patients, for people with diabetes, what is better for healthcare providers. The great problem are those who make decisions in the countries. Healthcare ministries, parliament, government, their inertia is horrible. It is very difficult to stop them. And what I'm really afraid of, WHO has becoming more and more active in pushing NCD prevention programs. They are acting on ministries of health and governments. And sooner or later, they will again want to do something better, but it will finish as always horrible.
Well, on that note, any final comments from the panel?
Yes, I'd like to just agree with what you've said. I'd like to move to Portugal.
It's much nicer weather, I have to say, Yvonne.
I think there is a political dimension to this as well, with communication. And I urge you to set up support groups, of peer support groups, or reference groups, whatever you want to call them. The patients are behind you, they're not against you, and they will fight for you. They can be a voice to support what you want to do, because without funding, some of this will not happen, and you need to lobby your governments.
Thank you for that, Yvonne. Pinar, any final comment?
Yeah, exactly. I want to echo actually that all what has been said. I think it's very important. People living with diabetes want the same as us, trying to provide the best care, whatever they need. But who is not in line with us are policymakers, payers. So we need to come up with common, join our strengths and as a civic society push for that.
Okay, well, on that note, we're going to be passing a diabetes resolution in the European Parliament this year in Strasbourg, so look out for that. And then number 2, do come to the World Diabetes Congress in Lisbon, a little pitch for that. I'm going to do some fireside chats with patients and policymakers, so you might be interested in hearing what the policymakers have to say when they're being challenged. So I'd like you to give a big round of applause to my panel, please. Thank you. Thank you. Thank you very much. I think it's your turn. I think, Dr. Kostas, you're chairing the next panel.
So good afternoon, ladies and gentlemen, and dear colleagues and friends. My name is Kostas Makrilakis. I'm a board member of Idf Europe. I'm a professor of internal medicine and metabolic diseases at the University of Athens Medical School. And I'm very happy and privileged to co-chair this second session of our symposium, which will actually continue on the previous topic of the relationship between healthcare professionals and people with diabetes. And we're going to talk about an initiative, the Guardians for Health, which actually tries to help with communicating the guidelines to the physicians and the patients alike, and Idf Europe is participating in this initiative. So I'm glad to also co-chair with my colleague here, Naresh Kanumili, who is a general practitioner with special interest in diabetes from Manchester, UK. And of course, you know already Yvonne Jones, our guest patient with diabetes, who is passionate with diabetes. And so I'm not saying anything new in this audience that type 2 diabetes is taking a big burden on this planet. We have millions of people with diabetes and many more with pre-diabetes, as we call it, that are going to develop diabetes in the future and they don't yet know it. Of course, diabetes is causing problems. It can cause potentially complications, microvascular and macrovascular. And we as physicians have the responsibility to inform our patients about these complications. Not to frighten them, but to let them know about them so they can do something to avoid them or prevent them. So I would like to ask you, Yvonne, when do you think people with diabetes should be told about the potential complications that they might develop? As soon as they're diagnosed, as soon as possible.
It can't be seen, it can't be felt, and so people don't take it seriously until they receive a complication. Did you hear what I said? Yes.
I repeated it, so you can say it again.
As soon as possible, as soon as they're diagnosed, and they need, because they can't see it, because they can't feel it, they don't take it seriously until something else goes wrong, which can sometimes be too late.
So you're telling me I should tell you the first time I meet you that diabetes can kill you and can cause blindness and can lead you to renal failure and on hemodialysis?
Yes.
How should I...
But it's the way you say it and how you build up that relationship with your patient. You don't need to have scaremongering posters or flyers, but you sit down with the patient, you make the time. It's worth making the time to see face-to-face that patient, either with a healthcare professional or with your GP, to tell them, because it saves time and money later on.
Okay, so face-to-face and a proper way of doing it.
Yeah.
Okay. So, Naresh, would you like to...
one of the things that you always said to me before as well about... one of the things you said, I think, when we were discussing it, about diabetes is a sneaky disease, didn't you say that, right? So,
yeah.
Well,
yeah.
you don't know you have it or until you develop complications, which you agree as well, don't you? Yeah.
You manage the diabetes. You don't let the diabetes manage you. I do not let diabetes, people don't necessarily know I've got diabetes because I manage it. I take care of myself, but I only take care of myself because I've had the information from the professionals on how to do it.
Okay, so people with diabetes might get complications, but it's very important that we talk with the physician in a proper way and face to face.
Yeah, face to face,
So,
not
Naresh,
virtually. Lots of people, particularly elder people, the people with type 2, although we know children are now getting type 2, but is it an older generation, particularly where I live in North Wales, which is a retirement area, people don't necessarily have the IT technology that we have here.
I think, Costas, one of the things is on the slide here, we're talking about life expectancy and things like that, and how do you expect the information to be given to people?
yeah, that's what we just discussed with Yvonne. How should I tell her that she's going to die soon? No, I mean, it's the way you say things. It's not that you are telling the patient, you know, you are going to die. That's what studies show as an average. That does not mean that all people with diabetes will suffer complications. It's very important to convey the information in a proper way and give them the good perspective that if they manage their diabetes, they will do well.
You start off by saying you're going to die, but if you say to somebody, you know, you could lose your sight or you could lose you suffer with retinopathy, or people will then know. And when they go on what we have in Wales, we have an expert programme for patients. They get this booklet that's very, very concise, but it's too much information in one go, so they need to have follow-ups, maybe 6 months, 12 months afterwards, because they come to me with the patient at the patient reference groups with this book and say, we don't understand it. They've had too much information loaded to them in one go. Else the booklet is excellent, but they don't understand it because they've had too much information pushed at them. But they do need to know right at the beginning what the outcomes could be if they don't control the diabetes.
And then we need to repeat the information down the road so that they absorb it.
I think one thing we know is, I mean, we've heard a lot of discussion in the previous panel about upskilling, or education seems a bad word for talking to patients about. I think we talk about upskilling them, giving them the tools. I think one thing for healthcare practitioners as well is about the number of guidelines that are available now, right? We've been told again and again what are the important things to do, and we still don't do it well enough. I mean, these basics like the ACE inhibitors, ARBs, and the statins, the simple things that can be done. And now we got these other therapies that are in play at the moment as well. If we can move the slide on once more.
If you mention structured education, you frighten them off. But those people who already feel educated are insulted, and those who are not very well educated don't understand what it means.
So yeah, for moving on from, actually I agree with you about the structured education and how we should be using language better. But equally, when we look at despite all the evidence that we have, less than 1 in 20 patients or people with type 2 diabetes and ASCVD are on guideline therapies. I mean, that's a phenomenally low number. Wouldn't you agree, Kostas?
Yeah, it's true that there are problems with the guidelines, and there are quite a few problems here. There's certainly a problem of knowledge and awareness from the perspective of the physicians. You know, especially the general practitioner. The general practitioners need more time than the specialists to acquire this information. There is a time gap from the time the studies are published, the guidelines are issued, to the time that the physicians know about it. And that time gap is usually some years. So I think things will get better in the future regarding the knowledge and the awareness of the guidelines, and that will help with implementing them.
Yeah. So I like the slide shows actually that all 3 evidence-based therapies only 4.6%. That's phenomenally low despite all the, we've been chucked at with, you know, evidence, and we are at a meeting where evidence all the time, but we still don't seem to be doing that. I mean, we're not doing a good job for our people with diabetes. So again, this is something from England. I think a lot of my colleagues from England will recognize this, that less than 40% of all people with type 2 diabetes achieve their treatment targets. I mean, that's a big driver in the UK. I suspect with the work that Niti and the team are doing with advocacy, whether this is something that should be done across the world. But if you think about UK as a place where people follow guidelines, we have NICE, etc. But still, I guess there are a lot of issues with regards to why that doesn't happen. And possibly we can pick up a few things around inertia. What are your thoughts on that?
Yeah, there are problems with inertia. Usually people just look and they don't do. They look at the glycemic control not being well controlled, and they don't act on it. And inertia is not only on therapy, inertia is on monitoring also. They forget to send patients, to tell patients to go for eye exams or to monitor the kidney function and so forth. So there is a problem with inertia, and that's why education is very important on physicians and patients alike, because when patients know what to expect from their physicians, they can ask for it also. So it's very important that we have educated physicians, but also educated patients. Patients need to take their responsibility also, I think.
Yeah. I mean, Yvonne, on your case, did any of your healthcare professionals actually talk to you about individualized targets?
Yes, they do. I'm very lucky in my case, I do. But in the wider community, it isn't always the case. And this is why I think integrated care is very important.
The other thing that we probably don't talk about much is about how diabetes affects not about glycemia alone, it's about the cardiovascular system and your kidneys as well. And I think we know CKD, etc., is a risk factor for cardiovascular disease, and equally roundabout, and how we communicate that to people with diabetes is important, I think. So we don't do enough of that. If I could get this slide moving, that'll be great. Yeah, it's just trying to reinforce what we just said now about the cardiovascular and the metabolic all interconnected. Yeah. With regards to care processes, what do you think of that then? I mean, one of the things that we ask is, has your healthcare team talked to you about the importance of urine tests and things like that? Because we know urine tests are not completed.
Yes, they have. They've spoken to me about ACR and EGFR, etc. I, unfortunately, have lost 3 of my close relatives with kidney disease through diabetes. So I'm very passionate about that, and I've been doing a lot of work with some of the healthcare team in North Wales to produce a leaflet on looking after your kidneys. And I've put in the patient's perspective, obviously not the medical perspective, and I've also looked very closely at the language that is used, because you mention ACR to a patient, they haven't got a clue what it means. True. So it's got to be put in terms that they understand.
I think it's simple things like, I mean, we're trying to do that in our practice, where the moment you do come to the clinic, the receptionist gives you a bottle to wee. And we kind of try and stress, your wee is important to us. So trying to get them to do that, because I think one of the things we try and avoid is, we keep saying we need an early morning sample. You don't need an early morning sample, because if the patient comes in, like you say, you don't want them to keep coming in and out. As soon as we come in, get the sample. Would you agree that's a good way to go about things then, Kostas?
Yeah, the basic thing is for the physician to know that he needs to order this sample, and this information, as I said earlier, there's a time gap for the guidelines to go into effect. And so this information is coming out now slowly to the physicians also, and they have started ordering kidney tests like EGFR and ACRs, the urine tests, and that's very important. Now remember, even the FDA back in 2008, when they issued these guidelines to the pharmaceutical companies to do all these big cardiovascular outcome trials, the main issue that they wanted to see was atherosclerotic cardiovascular disease. They did not have kidney function and heart failure as a basic thing to monitor. So we learned all these years that it's very important to monitor these things, and this is coming out slowly. I think it's very important.
I think here's an important question for everybody to think about. I think, what is your greatest area of concern in relation to treatment inertia and type 2 diabetes? I think we can target that question not just to healthcare professionals, but also to people living with diabetes, because as you said before, you'd want to take control of your condition, but we need to be able to give you the tools to do that. And one of the things that actually one of our colleagues, Kamlesh Kunti, has done is about talking about inertia and how long it takes before we initiate therapies. And I think if we can move on to the next slide, I'll show you some information that says it takes about 2.9 years before we can do the next step in therapy. So what are your thoughts on that, Yvonne, about why it's taking so long for us to...
I think it's, well, I'm very surprised to learn this. I think it takes far too long for results to come back. You go to the GP and the receptionist tells you, you get your results in 10 days' time or a week's time, and I know for a fact that you can have the results the same day if it's needed. So you're taking too long to get back to the patients, and then they lose confidence in what you're doing.
Absolutely. What are your thoughts on the inertia? I think you touched on some of the things already, Kostas, but any further thoughts on about why inertia is just a huge issue for us?
Yeah, we need to devote time to patient communication. We need to look into the whole organism, not only specific organs. and we need to decide globally how we will take care of them, not only from the glycemia, but from the complications. So we need informed physicians and informed patients to communicate. So that takes time.
One thing that the patients do lose confidence in is being asked to ring the reception desk for the result.
I mean, that is unique to the UK, obviously. So I think we've talked about it in the UK about, you know, how we label the result is important. In the UK, we tend to put abnormal, continue current plan. And the patient rings up and they say abnormal, continue current plan. And the patient says, well, nobody's told me I had a plan. So you think, oh, okay. So we haven't communicated that to you. So you don't know what to do next with that regards to that.
We also have in Wales, I'm assuming it's the same in England, but I don't know about other countries, is that we have the 15 essential care essentials, things like your retinopathy and podiatry and having your HbA1c, and that should be given to patients when they're newly diagnosed, because then that is their checklist of what they know they should be entitled to. And that, together with structured education, that also helps to drive them to manage their own diabetes. They need to manage their own diabetes with you as supporting them, not the other way around.
Yeah, it's very helpful that the patients know things from the beginning, what to expect from their physicians, what to do, and start having some knowledge and be repeated, because diabetes affects the whole organism. It's not only one organ, so it's the whole medicine. I mean, it affects the heart, the vessels, the kidneys, the mental and psychological health. It's everything. So you need time and construct and build on every physician visit, and the patients take the responsibility also.
I completely agree. So, like I said, again, we're at EASD and we're going to get tremendous amount of guidelines, and there's no reason for us not to implement these. I think we need to look at ways of doing it better. I think one of the initiatives that we're going to talk about is around Guardians for Health, which is actually a unique initiative. It's a global initiative to try and see whether we can reduce more early mortality by reducing cardiovascular and renal complications in people with type 2 diabetes. And I think it rests on what we call the medical essentials, which is assessing for comorbidities and modifiable risk factors regularly, which is something we should be doing. And probably this is something that we probably need to engender within our people with diabetes. Look, I need to have my blood pressure checked regularly. I need to have my cholesterol checked, my urine checked. So that's something that we can discuss with you more efficiently. And then use medications. You know, again, talked about trials and everything, but we're not using the medications enough. Because in the UK, if you look at the use of the new therapies such as SGLT2s, is like 10–15%, and GLP-1s is even lower. And we've got so much evidence for it, but we just don't use it enough. And again, Costas touched on some of these things around inertia and why things might happen. And last but not least, individualize and achieve targets. Again, we talked about that a bit, but again, we discussed that, you know, in your case, people do, but you also said in lots of other people you've encountered, they don't discuss what is my target for my blood pressure? What is my target for my HbA1c? They don't do that often, do they? Do you do that in your practice, Costas?
Yeah, we need to discuss it with the patients. It always comes down to time and how often we see them. So we need to discuss lifestyle measures is very important. Stop smoking, eat in moderation, lose weight if you're overweight, start moving around, not sitting all day long, increase your physical activity, not necessarily do sports, but increase your physical activity. So all these things should be discussed. It's not only medicine. These lifestyle measures are very, very important, and they complement the medicines.
Absolutely. Again, I think it's important that every time you bring a person with diabetes in, that we need to try and impress upon the lifestyle measures, no matter whether you're up titrating medication or not. And I think this just brings us quickly into something what we call patient-centered care, you know, shared decision-making. So what does shared decision-making mean? I think the previous panel discussed it quite elaborately about what shared decision-making, that you need to be in the center of it. What's your views on shared decision-making, Yvonne? What's happened with your situation?
Well, I'm lucky in that I'm part in the center of every decision that's made about my care. But some people are frightened to know, some people don't ask, and some people don't understand the importance of the knowledge that's being given to them. Some healthcare professionals are reluctant to share information, or that clearly for the patient, and it's important, I think, that we have to work together.
Yeah, I think what Yvonne just said is very important, to individualize treatment. I mean, you have to know your patient. Some people do not want to get the information. Some other people need the information. So you have to try and give the information as best as you can in the proper way. The usual thing we discuss with the patients is to start insulin when they need it and they are resistant. So we need to talk to them into the benefit of starting insulin, and because they have the idea that, you know, the neighbor started insulin and got blind. Yeah, but he had started insulin years ago.
Yeah.
So all these things are very important.
Absolutely. So we're running out of time, but quickly I want to take you through the concept of Guardians for Health around community, things like that. So the information is available. We'll put a QR code for you to scan and just have a look at what else Guardians for Health offers. But the main thing focuses around what we call community of implementers. That is looking at all of us as healthcare professionals actually taking forward the guidelines and pathways, etc. Tools are available as well. And the main thing to remember is whatever you do, just do some quality assurance on it. You need to know whether what you're doing is working, and if it's not working, you need to change it. So I think we'll bring it to a close quickly because I can see Neeti staring at me, and it's not a good stare. So I'll just put these things up on the screen about what the tools are, so I won't go through them with you, but there are a lot of tools available on the website. If you visit Guardians for Health website, you should be able to find that. And my colleagues are around who will be able to share the QR code with you so you can access the website as well. I'll bring that to an end.
Yeah, so this initiative, the Guardians for Health, you can access the tool from by scanning this, and you get all the information you need. And we're happy that IDF Europe is collaborating with this initiative, and we're going to have cards, I think, at the IDF Europe booth from tomorrow. And anybody that wants to ask any more question and get more information is welcome to come. And I know Yvonne is leaving early tomorrow, so she will not be available in the booth, but anybody who wants to ask her something, she'll be available right afterwards.
Thank you so much.
We thank you very much. I don't know if there are any questions, any quick questions we can take. Otherwise, yeah, please.
Thank you for that wonderful talks by all the panel discussions. Now, I just want to add one thing. That is about giving the information to the diabetic patient, especially when they come for the first time with a high blood sugar level. They are already in diabetic stress. The stress is very important. Now, we have to increase our vocabulary. How we tell them what has happened, what is the mechanism, why this diabetes has happened, and we have to give little bit information about how it happens, and then in every visit, we should discuss about this thing, and we have to be positive about his behavior and his activity in every visits. He has not lost weight. Thank you very much. You have tried.
We agree. We need to go slowly and persistently.
Yes, in all the visits.
Yes, absolutely. And there was another hand at the back. Yes, please. Oh, two. Okay. You have quick questions and quick answers.
I'm also from India, and following my senior's perspective, I would like to say that since it's a European Society meeting, we are trying our best. And whatever has been said today, we are trying, but I wanted in this panel, it's more of a comment, a clinical psychologist, because the mind and the body cannot be different. Whatever we are discussing today, it's all science, and we have a real advocate in terms of, Madam, she's explained, but we want that, I wanted to hear more about the motivational interviewing, the shared decision making, and all those things. So I lack a clinical psychologist in this panel discussion.
So one thing again we'll point out to you is if you were to go onto the website, there are some videos which actually talk about exactly that, motivational interviewing. How do you talk to a person with diabetes?
Because language matters.
Absolutely, yeah.
And we want that change talk, and I'm talking on those lines. So this forum should have been more brightened by a bit of that, because we always practice science, evidence-based, talking about clinical inertia and everything. But in this forum, I would have liked that part. Thank you.
Absolutely. Yeah.
Hi, so I would have a comment. I come from Bosnia and Herzegovina, which is a very small, under-resourced country. I live with type 1 diabetes and I'm a nurse, and a comment on patient inertia and maybe that part regarding type 2 diabetes. So I would say in under-resourced countries, you would have to acknowledge that a lot of people aren't aware of the severeness of type 2 diabetes, and that it's not that they don't want to get education, it's not that they just can't get education. So we are severely understaffed. So a lot of migrations, a lot of doctors that are already going to retire, so they don't have the time and resources to invest in their patients. And I think it's very easy to point the finger at patients, but that we need to look, especially when we talk about low-income countries, low and middle-income countries, that there are a lot of circumstances that affect the way a person is going to approach their self-management, because they need the right tools and they need the management and support from their healthcare team, and not to be blamed for something that they didn't cause.
No, absolutely. So if you look at picking up on structured education, if you look at the UK, referral to structured education is 98%. Attendance is 11%. And that's exactly why we need to look at how we deliver that. How can we help people with diabetes access it in a friendly manner, in a timely manner, where they can access it. So it does not mean that you have to go to a room, sit down with 10 other people. Can I give it to you in another way? Or how else can I do it? So
exactly.
Everybody's looking at different ways. Technology helps, but again, not everybody knows how to use an iPhone. So that's a big thing. So absolutely right. I mean,
and exactly. And when we talk about patients taking the responsibility, when you get the diagnosis, you just have to take the role of your own doctor, Yeah. So you don't get to decide whether you're going to do it or not. And sometimes we all just get tired of it. And the mental burden that comes with type 2 diabetes is also very big as with type 1 diabetes. So I think the responsibility is there, but we can't say that the people living, especially with type 2 diabetes, can just force themselves too much, if you understand what the point, what
Absolutely,
I'm
going. We need to be empathic.
Exactly. So a bit more empathy, and not looking the patient as a patient, but more as a human that also has emotions and other needs.
It always comes down to time, how much time they are giving you, because we as physicians also are pressed from time.
Exactly. And even in under-resourced countries, you have one doctor that is treating probably 3 times the patients he needs to treat. So I also understand that the HCPs are very understaffed, and that we need to help them too, but they need to help the patients then. It's a chain, but it's a good point. So
one quick question from Elena.
I have no questions. The presentations and all your speeches were wonderful. I have a comment. Being an educator, I want to say that today education has gone far away beyond the borders of just education. It is motivation, psychological approaches, so many things are included in education that we want to receive results that, to my opinion, it should be a university education to be an educator. There are very specific skills that each person who works as an educator should have. My second specialty is just junior and senior pedagogy. For 5 years, they were teaching me how to teach people. That's why I know that it's not enough only to want to share your knowledge. If we only want to share knowledge, we receive what happened with you, a wonderful booklet that a person reads, understands nothing, and stays not motivated. So education today needs just to be overlooked, and we need to make many changes to make it effective and to make our people, sweet people with diabetes, really happy and satisfied. Thank you.
Okay, thank you very much, Niti.
Thanks. I think we've got our next panel now. I'd like to invite onto stage our next panel, Mia, wherever you are. I can't see anything. This is where are you, Mia? Well, there you are. Come onto stage, please. Manuel, Thank you very much for being here. And Tatiana, where are you? There you are. I think we have enough mics for everybody, yeah? Please, wherever you like. Please take a mic each. So don't run away, all of you. I can see you leaving. Don't run off. Please stay with us. We've got our final panel of the day. And just to remind all of you, oh, hello. How are you? Good to see you. An old friend has just walked into the room. I couldn't resist a hello. We're going to talk about clinical trials now, and it's not going to be a boring subject. We're going to talk about the role of the patient. We're going to talk about the role of primary care, how decentralized trials can really work, and does it empower people with diabetes. So I'm very delighted to welcome onto this panel our esteemed guests. Can we start with you, Mia? Would you like to introduce yourself?
Yeah, hi everybody, my name is Mia. I'm a type 1 diabetic. I'm also a type 1 diabetes advocate. I actually work with IDF Europe as a project coordinator for the EU projects, and I also run the patient expert panel for the Trials at Home project, which we are very proud of how well it's going.
Thank you, Mia. Manuel.
So my name is Manuel Castro Cabezas. I'm a scientific officer at Julius Clinical in Zeist in Utrecht, which is an international CRO. But I'm also a clinician, a practicing endocrinologist, and also registered in internal medicine and vascular medicine at Franciscus Hospital in Rotterdam, and I'm associate professor in endocrinology at the Erasmus Medical Center, also in Rotterdam.
Gosh, you're a very eminent man, and we're so delighted to have you here. Thank you so much. Tatiana.
And I'm Tatiana Milenkovic. I'm endocrinologist, and I'm working in the University Hospital of Endocrinology in Skopje, Macedonia. And I'm also professor of internal medicine at our faculties in Cyril and Methodius in Skopje.
And also IDF board member.
Oh, it's very important, of course.
Absolutely.
Very proud.
Since this is an IDF web seminar.
IDF Europe board member, yes.
Correct. So I'm going to just throw open some questions, and you know, please intervene, guys. I think we'd like this to be as interactive as possible, not just the panels being asked questions. Just throw in questions if you fancy it. I'm going to ask one quick question. Mia, you can start on this one. Does the participation of people with diabetes in a clinical trial, do you think it would modify or strengthen the healthcare professional patient with diabetes relationship at all? Or does it not matter? I mean, it doesn't just say no, but you know, what do you think?
No, definitely. That relationship will be much more stronger after the clinical trial, especially since the patient that's involved in the clinical trial gets more support over time, establishes a better glycemic hygiene, to say, and therefore has better health outcomes regarding that support that he got or she got at the clinical trial. So the involvement of the patient not only means that the patient will have better health benefits themselves, they will therefore spread it to the community and say all the wonderful things that they've learned in the clinical trial regarding their own health and the overall care. So yeah, it's a definite plus.
So I'm going to throw it open here. Anybody with diabetes, have you participated in any clinical trials, anyone? Hands up if you have. Please, would you, oh, here we are, Kyle. Lots of folks here have participated in clinical. What do you think? Do you want to say something? Guys, please, would you like to say anything? They're all staring at me at the office. This wasn't part of the script, so I'm just making it up as I go along now. That's me.
I personally found the lack of feedback after I participated in the clinical trial was really quite disappointing. I was in... Okay, sorry, is that better?
Yeah, that's better.
I personally found the lack of feedback as a participant within a research project very disappointing. I had to go and Google the keywords that I knew were in it. I had to go and Google Scholar, the authors who I had consented to. I still had their names. The trial I was in was actually part of the DAPIT, Diabetes and Preeclampsia Intervention Trial. I never knew if I was in the placebo group or if I was in the active intervention group. However, I did develop preeclampsia. It was pregnancy number 4, so there's a high chance I was in the placebo group. But it's, whenever you're involved in that, you invest so much time, you do behaviour modification on your part as well. As a researcher now, I'm saying that's a really bad thing, but you do, you modify your own behaviour to improve the outcomes. But it's so disappointing whenever you don't get the feedback from the research team and you have to go and find published research that was published within 2 years of your baby being born, and you're finding it 10 years later.
That's so important one, and I'll bring all of you in a minute. What's your response to that, Manuel and Tatiana? Manuel, have a go.
Well, it's quite a shame because I think that it's an obligation of scientists and researchers to provide feedback on the individual results of participation in a trial. So I'm very sorry that this is your experience. Usually in my team we work differently and we provide the feedback to our individual participants.
Well, Tatiana?
For sure. I think so that this is very important because they are committing so much time and effort to be part of the trial, so they must know what is the outcome of the trial, and it's our responsibility as persons who are responsible for conducting the trial to inform our patients. And I'm doing that always, really, because I do have experience in trials, and I know that the patients are quite keen to know if their new drug or some new approach will eventually help them in the future.
And do you think, Tatiana, that doing these trials and being part of a trial strengthens your relationship with your patients?
Absolutely. Even during the, when you are speaking with the patients about eventually participation in the trial, and during the trial there is a more frequent contacts, visits and everything, and of course the patients are, our relationship becomes better in some way, but we have to prepare the patients that the trial will finish eventually. And this is not, it doesn't mean that we will stop to communicate, but we cannot continue with that frequency. But still, it is my experience that my relationship with those patients that were participating in the clinical trials are excellent even now, so many years after the trial.
And your view on that, Manuel?
No, well, I agree with you. I think it's not only important for the patient, but also for the researcher, for the healthcare provider. And I truly believe that because of the interaction between both, the relationship will also improve. So I fully agree with you.
Thank you. The compliance of patients will be better if we do have a good relationship with him.
They all need a doctor like you, Tatiana, for sure. So there was somebody else here who had something to say on clinical trials. Kyle, would you like to have a go? Here's the mic for you. Elizabeth was roaming around with the mic, but she's vanished.
Well, first, hello? Can you hear me?
Yeah, we can hear you.
Kyle Jacques from IDF Global. I'm really excited to see this topic being addressed head-on, first of all. And my experience is both as a person living with diabetes in a trial, but also as working for companies that are conducting trials. So I understand strategically the objective of some of these trials, but personally, even though I had that understanding, it was difficult for me to take a step back. And even if whatever I was experiencing in the trial, in my case, it was an artificial pancreas system, hybrid closed-loop system at the time, and wasn't necessarily working the way it should, to try to look at the longer picture, the longer perspective, that this failure, in quotes, could help someone else with diabetes down the line. That was the hardest thing for me to understand as a patient. I think that was also really exemplified if anyone's seen the movie The Human Trial by Lisa Hepner. It addresses this topic as well. So I'm just curious about that.
So thanks, Kyle. So we've had some, an important issue being raised here, and I'm going to throw this open to you, Manuel, because you're a scientific officer, you design trials. Here's somebody who's telling you they can't see the immediate benefit of it, but they know it's going to be an important question to be answered. How would you involve people with diabetes in designing trials? How do you think that works?
Well, by being very honest, we need research to provide innovation and increase the grade of care that we give to our patients. But we cannot guarantee that every trial that we'll do will be a success.
For sure.
But if you don't do the trial, you'll never get the answer. So,
correct.
So a good grade of communication is very important, and manage the expectations, of course.
Yeah. Tatiana?
Well, I think so that in some trials it is very important to involve the patients in some advices how to organize the trial. I think so, especially about the visit schedule, or for instance the titration algorithms. Their experience can be very helpful. What will be the targets for titration algorithms? I think so that the patients can be beneficial.
Thank you, Tatiana. That's a very important question. So there was somebody at the back there who also participated in a trial. Somebody put their hand up. Was yourself. Please come forward. Would you like to say something? And the reason I'm drawing you guys in, I think it's very important. Oh, we've got somebody there as well. But please go ahead.
So my experience was with Flash when it first started coming out, and actually I found it quite beneficial because I got feedback, and it altered what I knew about my diabetes. It altered what my team knew about my diabetes, and together we were able to make sure that I had the right tools to manage. So I found that a really positive experience, but versus doing blind studies with it, which was really disconcerting. So I think it can have a really good impact on the interaction you have with your healthcare team, but it does also depend on the feedback that we as the people participating get.
Thank you so much, and thanks for sharing your experience. We've got one more comment there, and I'm going to come back to the panel in a minute.
Hello, can you hear me? I can't stand because my knees won't let me stand, I'm afraid. I belong to the trials at home, and I believe that patients should be part of the panel that actually help with the setup, the actual trial before it even begins. Because if we're not there at the beginning, you may think that's what we need, but is it what we want? And I think that is more important than anything. It's all right being part of the trial at the end, where you're actually being given some medication or whatever, but that's too late. I think we need to be much more involved in all structures. And we're not just patients, we do have education as well. So we can be very useful.
Thanks for that. So we've had a comment here, and this is about kind of decentralizing trials. So we could talk about that in a minute. But we've had a patient say, I would really like to be involved in the design of your trial. I think Tatiana partly answered the question, but also asking the research question, if I actually understood that correctly. Did I understand that correctly? So how do you respond to that? I'll start with you, Manuel, and Mia, and then Tatiana, on the patient being at the center of designing the question, of actually asking that question and researchers following that through.
You know, nowadays I don't think that it's really possible to do big trials without having patient participation. And I'm used to have patient organizations always in the beginning of the design of trials. I truly believe that the inspiration to develop the design or to have the questions related to research are all derived from the interaction between patient and healthcare provider. So it always starts at the clinic, when you see a patient. Whether you can develop or design a study all the way from the beginning, only depending on the needs of patients, that should be probably the case, but it's not usually practical. But they should be involved, patients, of course.
Mia, what's your opinion of that? It might be different.
Yeah, to continue on your thoughts, one of the things we're trying to emphasize in the Trials at Home project is the importance of having a patient expert panel, which from the beginning of the trial was such an important part of the development and the logistics of the overall design of the project. Not only does the PEP are involved in the overall giving opinions regarding certain things. They're equal partners regarding the overall development of the whole logistics part before even the clinical trial is implemented in the phase of having patients actually test out the methods or the medication or anything. This methodology can be implemented not only in decentralized clinical trials, but in so many different projects outside of medicine, and that's the main thing we're trying to emphasize. And it has been such a positive impact regarding the overall progression of the project. So
I hope that answers some of your questions here. And I think IDF Europe are a big part of Trials at Home. You're going to talk about it right at the end, could tell you really what we're seeing, but this is some of the positive stuff that we're starting to see. Tatiana, did you want to talk anything about the core design of trials with your patients, actual design of the trial?
Well, I agree with the things that they said previously, that patients can contribute to the design of the trials, of course, and they should be from the beginning, because they will be the main participants, so they can share if they think that this trial can be done. It is something that it will be extremely difficult for somebody to do, because we have to start out of their perspectives. If the trial is actually possible to be run out and to include the different patients, so they should be a really important part.
Thank you, Tatiana. So here's, I think we were supposed to talk about decentralized trial, and I see my friend Pinar sitting in the audience, and I might throw it open to you in a minute. It's about how does decentralized clinical trials, which means, you know, not just doing them in a great big hospital, in a fancy building, in a research center, but also just doing some of these trials in primary care, possibly in community care. You know, what do people feel about that? And perhaps I'll throw it open to the consultant, the endocrinologist who does work in a fancy hospital. And I don't know if it's a fancy hospital. I think
yes,
it is.
Of course.
Yeah.
In Macedonia, upon to our standards.
Beautiful country. Come on.
Yes, it is. Yeah. But I think so that even up to now, the clinical trials are not just on our facilities. We do have a lot of telephone contacts and other kind of contacts, and I think so that this time during the COVID shows us that the real serious clinical trials can be done out of the hospitals on many other ways, and with that we can spare the patients of so many traveling and maybe stresses that they have in our hospitals. So I think so that a lot of things, not all the things related to trials, but a lot of activities can be done out of the hospital and decentralized.
And Manuel, are you starting to do some of that?
Yes. Just another remark. In the Netherlands, for example, more than 80% of all type 2 diabetes patients are seen by GPs.
Correct.
So if you want to do research in type 2 diabetes, then you should have, you need to have also the GPs on board, because they have all the patients. And Trials at Home has designed a very nice trial, which is called Radial. It's a decentralized trial in which it's a pan-European trial in which we will test whether participating in a clinical trial on a remote fashion is just as good as the conventional way of doing it, going to a center where you will see healthcare providers and doing the trial. This trial will also include a hybrid arm as a comparator. So we'll have a remote arm, a hybrid arm, and a conventional arm. It will be carried out in 6 or 7 countries in Europe. It will include 600 patients, type 2 diabetes patients on basal insulin, not on target. And we will use Glargine 300 as a therapeutical agent, and we hope to have a similar level of improved diabetes control as in the conventional and hybrid arm. But we need to do the trial and see what happens, and patients have been very much involved from the beginning, so we look forward to do it, and the first patient will be included, the first person with diabetes will be included by the end of this year. So regulatory has been gone through and approved, so we are very positive.
Well, thank you for sharing that. Pinar, would you like to make a comment?
Actually, I think this panel was my favorite, although I was...
You did the other one, eh? Come on.
Yeah. Actually, maybe next year we should do something specifically about this, I mean, as IDF. I think it's very, very important to think of study design, Niti, that's what you said, because quasi-experimental trials are the thing in primary care. So the more rigorous your methodology gets, the more you move away from reality, and then there's this big famous, thinking of dear Kamlesh, effectiveness efficacy gap, and there's so elegant study designs in the quasi-experimental group, like, the crossover, that you do not necessarily always have to do this rigorous state-of-the-art randomization, but you can still compare groups. And when we want to avoid, bias and confounding with our state-of-the-art randomization, we introduce a much bigger hidden confounder, which is that we just move everything away from real clinical practice. And now the thing is all about real-world evidence. Even the FDA wants those results. So in primary care, we can do very, very nice trials, clinical trials. And the good thing, for instance, if you do something like a crossover, and you have the people who will be participating in the trials in your panel, when you initially design it, they will feel much more empowered, because the same person will be able to experience 2 different interventions, and that's that's maybe the most realistic comparison one can get, sort of an N of 1 trial in a group. So I think next year IDF should do something.
We'll leave that with Nibosa. So thank you very much for that intervention, Pinar. I'd like very much to thank this panel for being such a great panel and such a flexible panel. Mia, did you want to have a final word on trials at home, or are you done with it?
Yeah, I can formally introduce our Pep Panel. So, like we mentioned, we have a patient expert panel for the Trials at Home project. It consists of 7 different people from 7 different countries in Europe. So, the diversity of the people participating in the PEP are therefore coming with such different backgrounds and opinions, and therefore giving an overall opinion of the community as a whole, not only having biased opinions or me-based opinions, as we like to call them. Their involvement has been such a wonderful addition to the project that it has basically positively impacted some of the designs and the questions that the overall people that are organizing the project had. Will this work? Will this not work? And the PEP have had an honor to basically had a way to give first-line input on how things should be done and what things can actually work in the real world with real patients.
Thank you, Mia. Over to you, Nibosa, for closing remarks. I think everybody's trying to go home now.
I would like, first of all, to thank all of you. The auditorium, it was surprisingly full of participants, so, or maybe not surprisingly, but even each year, even better and better. And thank you very much. And thanks to all the panelists. And if I have this difficult task, in fact, to summarize what we have said and what is the message. First of all, there are tons of literature, different tools and the others, how to educate physicians at the primary care level, but it seems to us, maybe I'm wrong, they are a little bit in a shadow in the course of the regular practice. Within these 8 minutes that in some of the countries the doctors have for their patients, they they cannot use it in a proper way, or maybe they don't use it at all. On the other hand, we have also a lot of fascinating models how the people with diabetes, can be educated, and they are implemented, and they are implemented in a number of institutions, but in a minority of institutions, unfortunately. And finally, on the overall level, the healthcare system, I should not say doesn't care of all this, but has not invested much in helping the primary care, secondary and tertiary care in diabetes to go along all these interactions and multidisciplinarity. And thank you very much for the colleague in India that he said for 35 years he was everything. He decided about everything, and there is something which was good in that. And at the level of primary care, the physician, the nurse, and the diabetes team is everything. They should decide in what direction the multidisciplinarity should go. They should decide what type of treatment the people with diabetes, the particular people with diabetes that they are curing, do need at this time. And this is multidisciplinarity in the primary, secondary, or tertiary care. And I think that we should send a very strong message that the health authorities, that the diabetes community, and IDF, EASD, whomever, should support this message. We should help the primary care physicians, where is the center of the good treatment of diabetes, with and enable much better interaction and enable much better multidisciplinarity, but not in a formal row of different exams that will have not a single consequence, but in a very targeted treatment of a particular patient in accordance to its needs. And if we succeeded to launch this message, at least a little bit on the other side of these doors, it would be the success of this meeting. Thank you very much again.